Okay, I'm hoping you can see my slides now.
We can. Thank you, JC.
Thank you very much, Sam, for that. That was really interesting and sets the scene really well for this presentation. So I'm speaking on the Perinatal Optimisation Toolkits, which has been an initiative that the NNAP and the BAPM have collaborated on over the last 18 months. Just moving on. So perinatal optimization is the process by which we reliably deliver evidence-based interventions to improve preterm outcomes. And the care pathway, which was established by the BAPM Collaborative, refers to those processes or interventions as they occur over time. So as Nick was talking about earlier, they don't just start at the time of birth, but there are several interventions that happen before birth that can improve outcomes. And we describe this pathway as starting really with the prediction of preterm birth, however you predict that, and I'll come to that later on, followed by some antenatal optimization interventions, place of birth, antenatal steroids, magnesium and antibiotics, and finish arguably with around about the time of birth when we have toolkits on optimal cord management, normothermia and maternal breast milk. And other practices around about the time of birth are recognised as improving preterm outcomes as well. But for the time being, these are the areas in which the BAPM and the NNAP wanted to achieve improvement. And clearly this pathway sits as the remit of the entire perinatal team and not just for one particular specialty over another. There are cross specialty working involved in each of these different areas. It also sits within a quality context, which has to be optimal really to make sure that we can embed quality improvement well and see the fruits of our efforts. And parents, obviously, their importance from the very, very beginning of pregnancy right through to after birth is so important, particularly in shared decision making. So the BAPM and the NNAP have collaborated on 4 specific toolkits, one starting with antenatal optimization, which was launched last month and which I will be talking about with a main focus today, but also these 3 other ones after birth as well. Normothermia you may already have seen, and that was launched last year. And I'm delighted to say that the maternal breast milk toolkit is going to be launched in the next couple of weeks, and optimal cord management, hopefully before Christmas. I've just seen one of the final drafts of that today, so that's looking exciting. And I want to reassure you all that these toolkits fully align with other national drivers for perinatal optimization and other improvement programs as well. And we've taken a great deal of care to ensure that the message is consistent across organizations, and we haven't duplicated effort, nor ask you to duplicate effort either. So there is an increasing imperative really to ensure really timely delivery of these interventions. And as such, there's a large number of organisations within the UK and internationally who are now driving antenatal optimisation in particular. Whether that's through the setting of standards, whether it's through benchmarking or implementation activity. And the BAPM and NNAP have obviously collaborated on these toolkits, with the BAPM providing the QI resource for clinicians on the front line who want to undertake improvement of these interventions, and the NNAP providing a measurement strategy and benchmarking as well. And since we agreed to this programme about 18 months ago, I'm really delighted to say that we have had fantastic input from the Maternity and Neonatal Safety Improvement Programme, MATNEO-SIP, who are committed to rolling out implementation of the toolkits over the next year or so, providing support and resource to help units within England get started and embed change. While in Scotland, the Maternity and Children Quality Improvement Collaborative have fully endorsed these toolkits and are putting them alongside their other very excellent resources for improving perinatal optimisation. So the purpose of the toolkits really is to provide the why in terms of the evidence-based for interventions, the what, so providing some best practice guidance, but I have to say these are not guidelines in themselves. We understand that the solution for different units and different networks can be very different depending on their context and processes and resources and so on. And we very much encourage people to look at the how, so subject-specific QI support that then allows units to choose from almost pick lists of different solutions that really suit their context best, so that's most appropriate for their own barriers to change. In addition to that, the toolkit provides resources, and so does the rest of the BAPM website as well. So you'll see that there are quality pages within the BAPM website now that you can visit. And we have a team of around about 15 to 20 BAPM members who are working on these areas of spotlight on safety. So that's a shared safety learning page that has various resources and improvement stories. The quality improvement toolkits, obviously. There are improvement stories in the QI storyboard, and some of you may already have been able to publish your improvement stories there. And we map these to the quality improvement toolkits as well. And lastly, there's the QI Made Easy section, which is a series of sort of bite-sized tutorials to help guide you and support you through some of the QI methodology that you may come across within the toolkits. So I encourage you all to have a wee dip into the BAPM website. But for now, I want to take you through the Antenatal Optimisation Toolkit. All the toolkits are written in the same format so that you become more used to the format over time if you're using several of them. And I want to just take you through the Antenatal Optimisation one. So although it is not a guideline per se, all of the toolkits have some broad brush aims. And for antenatal optimization, this is really all about trying to maximize the number of women who receive the interventions for which they are eligible. And the reason for this is that there is therapeutic time windows for steroids, magnesium and antibiotics, such that if they receive these interventions out with those time periods, the effect may be diminished or absent, in fact. So there's a big focus on the accurate prediction of the timing of preterm birth, whether that's through preterm labour or medically indicated preterm birth. And the prediction part of the toolkit is really strong, talks about obviously a detailed history, but using other technologies such as quantitative fetal fibronectin and cervical length, combined in the current QUIP app, although other methodologies are will be available, and in medically indicated birth, placental growth factor. And I'll come to these a little bit later on. But as well as guiding the timing of these pharmacological interventions, accurate prediction is really important in informing in utero transfer so that we get the right mother to the right place at the right time, so that if she is delivering an extremely preterm infant, that they have the best chances for a good outcome. And I'm just going to talk a little bit about the evidence for you. Firstly, around prediction of preterm birth, we know that women who've got a preterm birth history, that they are more likely to give birth preterm next time around. And it's about 15 to 46% of women will do so who've had a previous preterm birth. But most women who give birth preterm do not have a history of preterm birth, so they will not be picked up by preterm birth surveillance clinics, for example. And so they often present in stages of preterm labour, whether early or late. And so we have to use other technologies to help us understand roughly when they're likely to give birth, so that means we can get them to the right place and give them their interventions. And so at our disposal, there is quantitative fetal fibronectin, which fairly reliably predicts preterm birth, less than 30 weeks. And when you add cervical length to that, and that's a modality that many units do not have, but it refines the predictive ability of quantitative fetal fibronectin and saves around about €500 per patient in terms of admission costs and so on. The QUIP app, and I don't know how well most of you will be familiar with this. Obviously, we have obstetricians and midwives in the audience, but the QUIP app has been developed by Andy Shannon and his team, and it puts together history alongside fetal fibronectin and cervical length to give a prediction of preterm birth within the next 7 days. And when this is used, it has been validated, shows that it avoids around about 90% of admissions, meaning that you can discharge women quite comfortably if their QUIP percentage is below 5%. In terms of medically indicated birth, the placental growth factor and placental growth factor ratios are a new test that is now endorsed and is being rolled out by the NHS Accelerated Access Programme across NHS England to try and reliably predict preeclampsia in women who are less than 35 weeks. And that's a technology that is being strongly encouraged that units adopt. We need to get out of the habit of thinking that steroids are good for lung maturation. Clearly they do that, but the headline really is that they reduce death by 30%. And there is accumulating evidence that that is as effective in babies who are at extreme preterm gestations as well. Clearly they reduce RDS, but also important morbidities such as intraventricular hemorrhage and necrotizing enterocolitis. And again, the extreme preterm evidence is mounting for benefit in those gestations as well. We've talked about the optimum timing being within 7 days of birth with a course completed 24 hours before birth. And Sam's just presented data that over 90% of women within the UK who deliver before 34 weeks receive antenatal steroids. But what that measure doesn't show us is how many delivered between 24 hours and 7 days. And the evidence suggests that only about a fifth of women who give birth preterm receive steroids in this time frame, and I think it's about 50% of women who receive steroids at all do not actually deliver deliver at a preterm gestation. So importantly, there is some mortality benefit if steroids are given a little bit closer to birth, but the benefits don't exceed 7 days at all. So it's really important that we're working together with our obstetric and midwifery colleagues to try and develop pathways that ensure that we get timing correct. Particularly as repeat courses will reduce respiratory distress syndrome, but they don't reduce mortality. And there is suggestion that they will impact on fetal growth. So again, accurately predict preterm birth rather than having a repeat dosing strategy is really important. So magnesium, as Sam has already talked about, given within the 24 hours before birth, this reduces the risk of cerebral palsy. We know that I think the national figure is 83%, but really a wide range, 74 to 94%, so 20% difference between units in doing this. Again, there are similar effects across gestations, including seen in the extreme preterm infant as well. And there's a little bit of controversy about whether or not a loading dose is enough or a maintenance infusion has to be given as well. And the evidence to back up the use of a maintenance infusion as well as loading, which is what's recommended in the toolkit, is that the optimal maternal level is achieved at least 4 hours after the loading dose, with the fetal level probably lagging behind by about an hour or so. So it's important to think about that in terms of, clearly having women on magnesium infusions is important for labour ward capacity and so on, but that is the current national guidance from NICE and also in the Precept programme. So we've gone with that to keep the message consistent. Obviously, antibiotics are important. They're often an afterthought when it comes to established preterm labour, because women, there's an imperative to get magnesium and steroids in as well. But the benefit in treating women who are known to be group B strep positive and who present in preterm labour, the evidence shows that this reduces the risk of group B strep sepsis tenfold. And as we in this country don't know whether women are group B strep positive or not, the guidance is to give that as soon as possible when a woman presents in established labour. In place of birth, we know now from a series of studies, some of them pretty large, that if birth of an extreme preterm infant occurs in a high volume neonatal intensive care setting, that mortality is reduced by around about 50%, and there are other important reductions in necrotizing enterocolitis, intraventricular hemorrhage and PVL as well. So again, really important to transfer before birth and not after. So we've kind of put this together in a sort of simple schema for education purposes within the toolkit, just presented the rationale along with the evidence that people can use if they're wanting to educate the wider team. But we also provide some best practice principles as well. We've given 3 of these, and the first one of these is improving awareness. And clearly you cannot give interventions to women to improve outcomes unless they present, and there's probably a bigger piece of work that the BAPM will take on next year on improving awareness, improving societal awareness of preterm birth, the signs of preterm labour, and the beneficial effects of interventions if women can present early enough. But awareness also encompasses primary care with GPs and community midwives being trained about risk factors for preterm birth and the signs of preterm labour, And once women get to secondary care, can they access the care that they need in a timely way? And so these best practice principles and suggestions here are not a mandate that all units have to have all of these different solutions, but there's an encouragement for units to look at their own processes and see which ideas and which solutions may actually work in their own local context. We've talked a lot about improving accuracy of prediction, but just want to highlight it's not all about suspected, threatened and actual preterm labour. There are medically indicated preterm births as well. And in these, both fetal surveillance and maternal surveillance are clearly important to be undertaken as well. The third principle is about improving delivery of antenatal optimisation interventions. And we suggest that units might want to use the mnemonic STAMPED for this, which encompasses the interventions we've talked about already, but puts parents really at the heart of decision making, and an encouragement that a delivery plan that encompasses discussions, intrapartum monitoring, optimal cord management and so on is developed, and that should aid communication between different teams as well. In addressing these principles, there are some recommendations for infrastructure, but again, these are not a mandate. And if units are already got good compliance in specific measures without some of these recommended infrastructure items, they should not necessarily change what they're doing. But we do recommend that each unit should establish leads for antenatal optimisation who will help to build a perinatal team culture with shared goals and responsibilities. Systems and triage to expedite assessment of women once they present, training packages, including simulation and rolling out of guidelines, and importantly, a system of exception reporting. And I'm going to come back to that a little bit later on because the toolkit helps you with exception reporting in terms of a tool that we have developed for you. We've used best practice high-performing units to build these recommendations, and many such units used prescription templates, pre-made administration packs, stickers and checklists to help the users on the front line deliver these interventions promptly and in a streamlined way. Talk about information for parents, obviously, and guide people towards the BAPM Extreme Preterm Framework for Practice, which has got excellent resources for communication for those of us who are consulting with families at risk. The Preterm initiative, which is a regional initiative down in the southwest, it's built around perinatal optimisation. Well, they use parent health passports in which various interventions and discussions can be documented, and it's really useful to help aid communication between units if women are being transferred between units, but also as a sort of a holding place for information for the parent themselves. Sam's already talked about place of birth and how about, I think, 75% of babies who are born less than 27 weeks are born in a NICU setting. It's a really complex problem to address with really complex solutions. But we would recommend that networks seek to establish combined maternity and in utero transfer policies, a central referral hub to try and minimise the amount of time that is spent trying to seek COTS. And there are some units who have a policy of auto-acceptance, or some networks that have a policy of auto-acceptance where women are just automatically accepted if they are less than 27 weeks. And mainly that works really well because not all of these women deliver straight away, and so capacity changes in the coming days and they can be accommodated. We talk about the support that is required that for clinicians in district general hospitals, not just in transferring women, but also in the decisions that have to be made in transferring and the discussions that are had, particularly around the extreme preterm infant. So I'm going to put sort of best practice and evidence aside and talk about the improvement journey, which is the same across all of the toolkits, but the examples that are described are different in each. This improvement journey occurs over 5 phases, from defining the problem through to implementing, embedding and sustaining. And it's based on a model that has been developed by the Academic Health Sciences Network. So those of you in NHS England will be well acquainted with this process. So in phase 1, this is where you define the problem, and the toolkit helps you to understand your data, and particularly in the context of national standards and benchmarking. It provides QI tools to help you understand process and context. And here you see a fishbone diagram, but we have other tools such as force field analysis and process mapping that can help you as well. And we provide examples to give you ideas about where to start, etc. We encourage the development of an improvement plan to structure your project using a driver diagram. And the really important areas of this part are the improvement stories that we have sought from high-performing units that we have identified from the NNAP online tool, which you can use yourself to find similar high-performing units in your area, or units that have the similar case mix as you do as well, and learn from them if that's easier. But there's some really nice stories within the document which may give you some ideas and motivation about how and when and how to start. The parent voice runs really strongly through all of the toolkits, and experience stories are really important in helping us really understand the impact of what we're trying to achieve. And we'd urge you really strongly to go and listen to your own parents and get feedback from your own users, because although the stories that we present are important, they may not provide the same relevance to you as your own parents would do. In developing a shared purpose, we talk about building a QI team and engaging stakeholders. That's the people on the shop floor who'll be carrying out your change idea. And we're all guilty of working in professional silos from time to time. And I think such is the imperative really for abolishing that kind of way of working and establishing much more functional, collaborative approaches across specialties. That the MATNAO SIP and BAPAM are working on a piece of quality work about building a perinatal team culture, and we've started that work now and hope to have that with you by the middle of next year. So look out for that. In phase 3, we encourage you to develop a project charter, not just to detail how your project is going to take place and what measures you're going to use to understand success, but also this can be used as a way of getting the resources that you might need, highlighting to senior management what your requirements are, and a lot of units find this process really helpful in that area. And then in formulating and testing your solutions, we point you to lots of different QI methodologies, but the model for improvement is used ubiquitously in healthcare, and I'm sure all of you are pretty familiar with it. And we give an example here of the three-stage questions that we ask in the model for improvement, and PDSA cycle, small tests of change, and what that might look like in an antenatal optimization setting. Clearly, to be able to measure improvement, you've got to be able to collect data, and we are pretty clear on making sure that we don't increase the data burden for you. We encourage you to use the data that you're already collecting for other organizations and dashboards, etc., and for Badger. But we do provide some additional measures to help you get more granularity on your data. And these are outcome, process, and balancing measures, and we describe the difference between these and what you might want to use should you want to explore your data further. In analysing and displaying your data, we talk about run charts and statistical process control charts, clearly exceptionally important in understanding change. And we provide QI tutorials as well on the BAPAM website to help support your understanding of these methodologies. We understand that these types of display can be quite impenetrable for your audience, and so we help you explore how you might modify your data to produce feedback that may be better suited to your wider team and importantly for parents as well. Lastly, in phase 5, we're talking about implementing, embedding, sustaining. We talk about spread, how you might do that formally and informally. As I've said before, there's a big focus on exception reporting, and I know that the NNAP recommendations are big on this as well. We have provided a tool that units and networks can download and modify for their own local use, which is obviously really important. In understanding barriers and finding solutions to loss of motivation, we describe a whole host of different techniques and solutions that may be helpful for you, including things like making the process easier for your frontline staff using stickers and checklists and stamps, etc. remarketing your message, so doing away with, you know, complex statistics and making your language much more plain for your frontline staff. And again, using parent stories such as this one of a mother of a 27-week gestation baby. Again, very important for the unit where that mother was born, to hear how impactful she has found the fact that she received those interventions before birth, and how that she feels that has made her baby healthier and happier. So getting started, you might want to download the BAFM toolkits that exist and look out for the maternal breast milk one and optimal cord management ones later in the month. Start talking about perinatal optimization across your team. Look at your data, understand your processes, build your team. Find solutions that are bespoke for your own local context, and spread the message and embed change within your system. And lastly, look out for the implementation support that's coming from that NeoSIP in 2021, and that's for those of you in England. The decision-making tool that's going to go along with that, which hopefully will be electronic, which will really help clinicians at the time a woman presents early in labour, and which is alongside parent information as well. And the Building Perinatal Team Culture, as I said, will be coming out next year. It just leaves me to thank the Antenatal Optimisation Toolkit group, but indeed all of the toolkit groups that have been involved in this initiative. Without, I think there's something like 60 members or 60 professionals who've been involved in this, along with parent charities as well. And they've brought so much enthusiasm and expertise to the programme. It's been a total privilege to work with them, and I've certainly learned an awful lot. Thank you very much.
Well, thank you very much indeed, JC. That's great. I hope you're going to be able to hang on and answer some questions.
Yeah, sure.
Brilliant. So hopefully it's hard looking at a screen where you're mostly black squares, but I'm believing you're all out there. We hope that you're going to send some questions in. You should have had a message to send them to Oliver Rackham. You can send them to Oliver on the chat. Oliver Rackham, R-A-C-K-H-A-M. I think he should appear on the menu there. With that, because I think Nick's no longer chairing, I think it might be me, I'm going to try and find the other presentation. Not like
I was wondering, because we're 10 minutes ahead of time,
okay,
if we wanted to give everyone a 10-minute break from the computer screen so they can digest what they've taken in and maybe think about some more questions.
Okay, let's have a 5-minute comfort break in order so that we can all finish 5 minutes early. How about that as a compromise solution? Because you're suggesting that some people might need to stretch their legs, so to speak. Yeah. That sounds like an excellent plan. So it's now 15:01, so that gives me 5 minutes to get my presentation up on screen. That should be enough. And we'll see you all at 15:06. Thank you very much.